Magnus, very happy for you to start.
So thank you very much, Alok, for that nice introduction, and I'm very honored to be speaking at this event and on this interesting topic. And I will start with, I will share with you some of the Swedish experience in active care of extremely preterm infants. I will start by going back in history. As you know, we could go back to the Viking Age, but maybe I won't go that far. Really, I will go to the 1980s, and here is a sample of Swedish fashion from the 1980s, and also a very Swedish tennis player, Björn Borg, in the 1980s. And what happened in neonatology during the 1980s in Sweden? Well, there were these guys here, Bengt Robertson and Ture Kjærstad, who developed a porcine surfactant therapy in the early 80s, which has later been commercialized as the Curasurf, which is actually named from these guys, so which is used already even today. And also there was very active development on CPAP treatment of preterm babies, and these are Kjell Nilsson and Gunnar Moa, who developed the so-called Östersund CPAP in a small hospital in Sweden, which later was commercialized under the name Infant Flow, and this was also developed in the 1980s. So there was a lot of development in Swedish neonatology and preterm care in the 1980s. And at the same time, there were reports of increasing survival of infants at 23 to 27 weeks and with a birth weight of less than 1,000 grams. And in the year 1990, the Swedish Board of Health and Welfare actually recommended that active care should not be offered before 25 weeks of gestation. And this was very, very controversial recommendation. And it turned out that some hospitals followed this recommendation, but some did not. And there was a lot of heated debate in media during the 1990s whether or not to give active care to these smallest preterm infants. And this debate led to something positive. It led to the first national study, which was called the 1,000-gram study. It was all infants born in Sweden between 1990 and 1992 with a birth weight less than 1,000 grams. And 10%, this was a strange number there. Okay, still. There were large regional differences in survival, and it turned out that 50% of these infants were born outside the regional centers, and the conclusion was that increased centralization of these patients was needed, and that long-term outcomes needed to be studied because there was really no knowledge about the long-term outcomes. There was many people feared that these preterms would get very severe cerebral palsy. Then the next important publication came in 2004, exploring these regional differences that had occurred because there had developed a more active approach in the north. I belong to this northernmost hospital here, marked in the north, and then we have Uppsala is another hospital here in the north. So the northern regions were more active and the southern regions were less active. And this study included 3,600 extremely preterm infants born between 1985 and 1999. And in the infants with gestational age between 22 and 25 weeks, a proactive approach resulted in an increased incidence of live births, more centralized management was observed also in those hospitals, and a higher frequency of cesarean section, and fewer infant deaths within 24 hours, and more infants surviving at 1 year. But importantly, no increased neonatal morbidity in survivors. So this will be a recurring topic, that a more active management will lead to more survivors, but no increased morbidity. And this was the first time that was shown in Sweden. And at the same time, because of all these discussions about the long-term outcomes of these infants, it was started a national quality register, which is called now the Swedish Neonatal Quality Register, or SNQ. It started in 2001 in some regions, and it had nationwide coverage for extremely preterms from 2004 and nationwide coverage for all neonatal care from 2010. And then another project which was started as a result of these controversies was then the second nationwide study, which was the Express study. Maybe you heard of it. It was a national prospective population-based study, including all infants born before 27 completed weeks of gestation during a 3-year period from 2004 to 2007. And the 1-year survival of live-born infants was 70%, 10% of 22 weeks survived, and it ranged up to 85% survival at 26 weeks. And there have been a huge number of publications from the Express cohort so far, about 80 of them. And one important publication came in 2015, where they looked at the perinatal care and later outcome. And they looked at obstetric indicators of active management, which was delivery at level 3 hospital, complete course of antenatal steroids, cesarean delivery, and tocolytic treatment, and neonatal indicators of active management, which was surfactant within 2 hours, delivery attended by a neonatologist, intubation immediately after birth, and infant admitted for intensive care if of those surviving at 30 minutes. And so the healthcare regions in Sweden were divided into 2 groups, those with a high activity score, which was 3 regions, and those with a low activity score, which were the 4 other regions. And it turned out that a higher gestational age specific activity score was significantly associated with lower stillbirth risk and lower 1-year mortality. And this effect was confined to the 22 to 24 week group. So more activity, better, higher survival. And also importantly, there was a lower risk of the composite outcome, death or neurodevelopmental impairment at 2.5 years in high activity regions. So among live-born infants, the odds ratio was 0.68. So there was a, 32% lower risk of death or neurodevelopmental impairment in the high activity regions. And among the fetuses alive at mother's admission for delivery, there was a very similar odds ratio of 0.69. And when just looking at the survivors at 2.5 years, there was no significant difference in the rates of neurodevelopmental impairment. They were almost exactly the same. So this study also reports that a higher activity level leads to higher survival, but not worse outcomes. And then there has been published a 6.5-year follow-up of the Express cohort. These of the 707 live-born infants, less than 27 weeks, 494 or 70% survived to 1 year, and 486 or 69% survived to 6.5 years, and 441% of them, or 91% of the survivors, were assessed at 6.5 years, 59 of them by medical record review only, and the others by psychology testing. And this was published in 2016, and these are the results. And here the outcome was divided into none or mild or moderate or severe functional impairment. And mild functional impairment was defined as an IQ of -1 to -2 standard deviations, a cerebral palsy with a gross motor function score of 1, or mild visual impairment. A moderate impairment was defined as IQ of -2 to -3 standard deviation, a CP gross motor function score 2 to 3, moderate visual impairment or hearing impairment, and a severe impairment was IQ less than -3 standard deviation, cerebral palsy with a gross motor function score of 4 or more, blindness or deafness. And as you can see here, the vast majority of infants in the blue bars here had none or mild functional impairment, but the risk of having a moderate or severe impairment increases as predicted with a lower gestational age. As I mentioned, there were very few survivors here in week 22 in this cohort, only 5 of them. So that's why they are a little shaded out here, because you can't really draw any conclusions from 5 individuals. So anyway, these results up to 2016 led to the Swedish national consensus guidelines, because previously there has, as I mentioned, there had been great controversy and great differences in the management of these infants, and actually quite a lot of discussion about this, and people blaming each other or being unethical and so on. Already when we discussed this in 2015, the Express study and the National Quality Register had already led to a more similar care in the different regional centers, but there was still a lack of consensus and still unequal care. And we had a workshop in December 2015 with the heads of neonatology and obstetrics at Sweden's university hospitals, and this resulted in national consensus guidelines, which are summarized in this table. So here it is recommended that if there is an imminent preterm birth in a pregnancy, the mother should be transported to a highly specialized center from week 22. Antenatal steroids should be considered in week 22 and should be recommended from week 23. Cesarean section on fetal indication should be considered in week 23 and is recommended from week 24. And a neonatologist present at delivery is recommended from week 22. Initiation of cardiopulmonary resuscitation in the newborn should be considered from week 22 and recommended from week 23. And there was a lot of discussion about this routine to assess the vitality of the newborn in these extremely low gestational ages, but it was decided that this term is poorly defined. If you observe an infant, a newborn, you can consider it to be not vital, but then if you put on ECG electrodes, for example, it's quite likely that that baby has some heart activity. So what is vital? It was poorly defined, so it was not used in this document. Now I will continue with the next big national study, which is called the Express-2 study, and is published in 2019 in JAMA. And this is a new 3-year cohort, 2014 to 2016, done in a very similar way as the original Express study 10 years earlier. So this was also, the difference was in the method of data collection, actually. So it was a slightly more simplified data collection in the Express-2 study using the quality register, which exists and validated against patient records. So in summary, this study comparing the Express-2 cohort to the original Express cohort, here the new late Express-2 is in orange here, and the Express is in blue. You can see that the percentage of, the number of live-born infants increased significantly in the weeks 22 and 23 between these cohorts, but no change in the higher gestational ages. So certainly this reflects a more active obstetric care. And antenatal steroids was significantly more commonly given in 22 weeks in the Express-2 cohorts, and also delivery at hospital with the level 3 NICU was more common in the 22 weeks. It should be noted that this cohort is from the new national recommendations came only at the end of this cohort. So this cohort reflects the practice slightly before and slightly after the implementation of the new guidelines. But still, there had been a change already before the guidelines. So I think it kind of reflects also the situation after. So we can see that there's more centralized care, intubation at birth. There was no major differences here. In week 26, there was a difference. Admission to NICU was more common in several of these gestational ages. And then the 1-year survival among live-born, there was a significant increased survival in 22 weeks, or actually overall, there seems to be a slight increase, and it was the most visible in week 22, where it was increased from 10% to 30%. The 1-year survival of infants admitted to the NICU also increased, even though it did not reach significance in week 22. But you can see there's a difference in the sizes of the bars. And this is a different way of presenting the improved survival in Sweden, which was summarized in a paper from 2018. And you can see here clearly that the survival of 23 weekers has increased from virtually zero in the mid-80s to more than 60% in the latest period here in 2016. And also you can see that the 22 weekers have appeared here in the latest 15 years. If you compare these results to other European population-based studies of extremely preterms, we can see that even the original Express study had a higher survival rate in this gestational age range compared to the EPICURE-2 and the EPIPAGE-2 in the UK and France. And then the Express 2, there was even a higher survival rate of 77%. And if we focus just on the 22 weekers, we had a 10% survival in the 2004 to 2007 year range in Sweden, and it comparing with the Japanese neonatal network, 36%, University of Iowa, 33%, and this is a paper with 24 US hospital with active care, 23%, and here in this Express 2 cohort in Sweden, 30% on a national level. So it's similar to what has been achieved in other regions in the world. But not only the survival is important, but of course, obviously the outcome, the morbidity and the long-term outcome is very, very important for the ethical questions on whether or not to give active management. So in the Express 2 paper from 2019, it's also presented the neonatal morbidities, and this is the statistics for intraventricular hemorrhage grade 3 to 4. And unfortunately, actually, we can see that there's seems to be even a reduction in IVH, severe IVH in the lowest gestational ages here, but there was overall no significant differences. And for cystic PVL, we can see a clear and significant reduction in the weeks of in the 23 and 24 weeks preterms. There were no cases in 22 weekers. Necrotizing enterocolitis seems to be an opposite trend with an increased incidence. However, I should mention that we are currently going through these data from the Express 2, and we think, first of all, these differences are not significant, and we are going through this data and trying to see if we can find any factors to explain this difference. We think that the actual difference is slightly smaller than seen here. But that's a worrying trend, though. Severe bronchopulmonary dysplasia was reduced in the higher gestational ages, 24 to 26 weekers, but not really any significant differences in the 22 and 23 weekers. ROP, we have quite a high incidence in Sweden in these extremely preterms, and you can see it increases linearly with lower gestational age, and there was no difference between these cohorts. And this is a summary picture then, the 1-year survival without major neonatal morbidities of infants admitted to the NICU, and with major neonatal morbidities here was included severe IVH, PVL, NEC, ROP of severe grade, or severe BPD. And as you can see, really, there was no significant differences. So this is yet another study showing that more active care will result in higher survival, but no difference in outcome and this is the neonatal morbidities. So what about the long-term outcomes? Well, I could mention that there is an ongoing study of the 2.5-year outcome of the Express 2 cohort, but this is not finalized yet, so it's ongoing, and it will hopefully be submitted for publication later this year, or very likely it will be submitted, but so hopefully you can even read it later this year. But while we're waiting for that, there was a very recent, very nice one-center study from Uppsala, which is one of these highly specialized centers with which have had always an active management, and this was published just 2 weeks ago, I think, in Archives, and this was all infants born at between 22+0 to 24+6 in Uppsala during 2006 to 2015. 224 infants. 2 infants were excluded due to major congenital malformation, and the survival rates here was, as you see here, these are the numbers, and the percentage of survival was 52% at 22 weeks, 64% at 23 weeks, and 70% at 24 weeks. And they present very nice data here for the neonatal or the obstetric data. We can see that the 22 weeks had a lower birth weight, which is kind of expected. They also had a difference in cesarean section with no cesarean sections in week 22, which is according to the guidelines. There was a higher percentage of tocolysis given, 95% in the 22 weekers. So that was very common. And among the neonatal complications, there were significant differences in ROP, with a 45% occurrence in the OPS in the 22 weekers as compared to 30 and 13 in the other weeks. Also, BPD was clearly more common. Severe BPD was more common in the 22 weekers with 77% compared to 43 in the other groups. They also had a longer length of stay and higher number of days on mechanical ventilation, 53 as compared to 45 and 34. So clearly these are much sicker babies, and they have a higher risk of severe BPD and ROP. What about the long-term outcome? Well, they have actually followed these children at 2.5 years, and they show here that there were significant differences in the risk of visual impairment. So we can see here 15% and 15% in the 22 weekers and 10% moderate severe, and there was a significant differences between these 3 groups. Also, developmental delay was significantly higher risk in the 22 weekers, with 30% having moderate to severe developmental delay at 2.5 years. And they had quite low numbers here at 23 weeks. They had some of these infants that were not possible to follow, I think. So you can see here, this almost a little too low, I think 9%, but still there was a significant higher risk for the 22 weekers with the total risk of 50% and 30% moderate to severe. So the unimpaired, if you combine all of these outcomes at 2.5 years, 50% of the 22 weekers were unimpaired as compared to 62% of the 23 weekers and 75% of the 24 weekers. So what about the clinical experience? People ask me when they have not been taking care of 22 weekers, what is actually the difference of taking care of 22 weekers? Well, I would say there's much similarity to 23 weekers, but they are even more fragile. First of all, they have a more severe pulmonary disease. They have both the early respiratory problems with the RDS and the so they clearly have a higher mortality, higher early mortality, and then they also have a more severe BPD or chronic lung disease, and they have a much longer time on mechanical ventilation, and there are some infants who actually do not survive the BPD period because they die later on from pulmonary complications. Also, they have more sensitive skin early on. They have a clearly higher risk of hypothermia, fluid loss. They have a higher risk of bruising, abrasions, skin infections, and tape doesn't stick or results in lesions. So clearly more sensitive and immature skin. They also have more severe early metabolic disturbances. We almost universally will observe hyperglycemia, hypernatremia, and hypophosphatemia in these infants. So they are a little more tricky to take care of. And I would say that there is also a difference in those born in the early 22, meaning 22 plus 0 to 3 compared to the 22 plus 4 to 6 days. So I mean, it's really a difference there. And also, of course, we see a difference between boys and girls and so on. But also, we have some very nice experience of 22 weekers here as a skin-to-skin situation, and we have later on a very happy girl. So we would say that the guidelines from 2016 have resulted in a uniformly active management of 23-week preterms in Sweden. But as you see here with the recommendation of just consider CPR in week 22, that means that the week 22 is a gray zone for active management in Sweden. And this allows individual consideration of cases, but it also allows some remaining differences between hospitals, even though most hospitals have become more active with the 22 weekers. And in those hospitals who have become more active, there's an ongoing ethical discussion between doctors, and there are some differences in opinion. We know this doesn't really apply to my hospital because we have been active all along. In these national guidelines, it's mentioned about parental involvement and decision making. It says that parents should be well informed, if possible, before birth and by the obstetrician and neonatologist together. A clinical decision should be made by the responsible physician in each case, considering guidelines, but also parents' wishes, as well as individual risk factors. But there are some issues here, and I have been doing a survey among some colleagues around the country, and we know regarding the parental input, there is a difficulty because it's quite well known that parents are very much influenced by the opinion and experience of the responsible neonatologist who gives them the information. And also, I think it might be special to Sweden that parents have rarely strong views on whether to resuscitate or not. I imagine that this is quite different in countries such as the US or Italy or somewhere where people are more expressing their opinions and feelings. In Sweden, we have a tradition of not expressing so much. So really, we get very little input from the parent, and most commonly, the neonatologist gives information and kind of notes the parents' reactions or comments, and there is not the tradition of asking a clear question to the parents. So we are very cautious both on the parent side and from the physician side. So I would say that there are, regarding the early management approaches, there is one approach of decision making during the neonatal stabilization, including the risk factors, parental wishes, if any, and the clinical picture, including this vitality, which is so difficult to define. So I think that would be probably the most common in Sweden, but there are also some centers which give routine active early management to all these 22 weeks if the parents don't clearly express otherwise, and then they later have a discussion with parents on whether or not to continue the intensive care. So those are the kind of main approaches in Sweden now. So in summary, the national guidelines since 2016 with active management encouraged from 23 weeks and with 22 weeks being the gray zone has resulted in improved survival rates. So at 23 weeks, we have now survival of 60% at the national level with very little variation between hospitals. And at 22 weeks, we have 30% at the national level and 50% at the centers with the most active management. And clearly at 22 weeks, these babies have a high risk of ROP and severe BPD, and 30% in this one center follow-up had moderate or severe developmental delay at 2.5 years. So clearly, we still have a lack of data on national cohorts of long-term follow-up in these gestational ages. So the long-term follow-up is monitored, and we are using this quality register, and we are aiming for quality improvement. When we have these open comparisons, so it's visible the results from the different centers. And of course, these national guidelines will have future updates based on outcome data. So I would like to thank you very much for your attention. I would like to thank our research group here and our funding agencies, and I'm now happy to take any questions.
So, I'd like to thank you, Magnus, for an absolutely excellent talk and giving us a very nice summary of how you would manage extreme preterms in Sweden. We've got a host of questions, and I'm going to start with probably going through the management just after birth. So we're obviously starting our journey with management of babies at this particular gestation. I'm going to be honest and frank to admit that we've only so far resuscitated 2 babies. And obviously with 2 babies, we're still learning how to manage them. I think I completely echo your sentiments on the fragility, of these babies and how I would say easy it is to damage their skin. My question at the moment is early management after birth. So delayed cord clamping. Do you feel a little bit more nervous doing that at 22, 23 weeks? And I mean, how do you assess the vigor and vitality? Because it's quite subjective in that you can't auscultate the heart rate with the baby outside. Now, we clearly, from our perspective, have got very low rates of delayed cord clamping, I would say actually under 28 weeks because of these anxieties. And I would just be keen to know what your practice is.
Yeah, this is an excellent question, and we are having a discussion in Sweden about this now. We have done and unfortunately, I must say, we still have the routine practice of early cord clamping and rushing the baby to the CPR table. That would be the norm below 28 weeks in our hospital, and I think in most hospitals in Sweden. But there are some. I know at least 1 or 2 hospitals that are experimenting with delayed cord clamping, even in the extremely preterms. But as you know, this requires a setup. There's a lot of logistics that has to be solved, but I think it's very interesting.
There's another question on that, kind of looking at resuscitation at birth. So, I mean, our previous guidance in the UK the old BAPM guidance actually talked about not giving cardiac compressions to babies under 26 weeks of gestation. That view has been challenged in our guidance, our new guidance, to kind of say that what we've got to do is assess each case, case by case, and look at chances. But just experience, do you have any views on cardiac compressions and adrenaline under, say, 26 weeks of gestation? How aggressive would...
I would say that it's quite rare that we give cardiac compressions and adrenaline. Usually, I mean, ventilation will, well, it's mostly like in the futile cases, and I would say it's quite, overall, it's quite rare that it happens. Either the baby will improve with ventilation, or it's quite clear that this baby has no chance. So that's my experience.
That's really helpful. We have a question from Vicky, who's one of our nurse practitioners. And one of the questions that she's asked, do you have a golden hour protocol and intravenous access? Obviously, putting cannulas in such small babies is extremely challenging. So umbilical venous access, but again, for babies, say under 500 grams, what's your experience and how do you manage access? How long do you keep your umbilical lines in versus long lines?
Yeah, so we usually would for lines, if possible, we would put in a peripheral vein catheter already at the stabilization table, and then we would insert umbilical artery and venous line. Sometimes, of course, these vessels are so small, so it's not possible, but in most cases, we will get central lines, and then we would usually let them sit for a little, for at least the first week, and sometimes longer than that, like 10 to 14 days at the most. And then we would substitute with a PCVK or peripherally inserted CVK.
Just another question that Vicky has asked is, one of the questions, obviously, we looked at the study that was done and the work done in Apostla and the difference between the North and South. How have you managed to achieve consensus around that? And I mean, just from an ethical perspective, your definition of active intervention, have you been able to standardize that across Sweden at the moment, or are there still slight differences in approach on a case-by-case basis?
Yes, I would say that for the 23 week, it is almost universal now that people are active. But in the 22 week range from 22 to 22 plus 6, there's still a variation between centers. And there's also, and I would say in some centers there might be even a variation between doctors. So that's the situation. Some centers will be very active and some centers will be less active. But the overall trend is that everybody has become more active the last 5 years or so.
Fantastic. So there's a question from one of our nursing colleagues in the audience about the nursing experience of caring for these babies, and just in terms of early sedation versus allowing them to breathe so that you can get them off the ventilator. Do you use analgesia and do you use morphine routinely in the 22-weekers who are intubated?
We would use, well, for the early intubation, we will not use any sedation, like the emergency directly after birth. We would not use any medication. Then if we have a planned intubation, we would give fentanyl and urticurium. That's just our routine. And then we would give sedation or pain analgesics like on demand. We will not give it routinely, but if the baby seems to need it, we will give it. So we would use sometimes, but usually the very, very smallest babies, the 22-weekers, at least in the early phase, they would not require so much sedation or analgesia. However, we are very, I mean, we try to reduce unnecessarily handling of them as much as possible. We try to let them sit skin to skin. So those are the approaches we have. I don't know if that was a good response to the question.
It was actually, and I think we manage babies, and we have a sister unit Portsmouth, and actually we have slightly different approaches to analgesia. In that, I think if we're planning to try and move a baby forwards who's extremely preterm, we'll caffeinate and not start sedation, and it's on a case-by-case basis. So the baby then stays on, and we think he's going to go for an extended period, then our use over here is morphine. So it's a pretty similar kind of approach to how you approach it over there. I'm going to open the floor now to questions. And Vicky, you have a question. So I don't know if Vicky can hear me. So
yeah, me, Vicky.
Yes.
Hi, Alok. Thank you for organising, and thank you, Marcus. That was a really interesting talk.
Magnus.
I'm not sure which question, Magnus. Sorry, I'm not sure which question you're referring to, Alok, because I did have a few.
Go for it. Go for it.
I guess one of the things, is about the nursing experience of caring for the 22-weekers in terms of their, attitudes and beliefs. And I'm guessing that Sweden has always come across to me, as quite progressive in terms of the gestations that they will actively resuscitate. So I don't know if it's just part of your culture that is maybe a little bit different to ours in the UK, but I wondered if there was any research evidence on kind of clinicians' beliefs and attitudes towards that.
I haven't seen anything specific for nurses, but there are some comparisons between Swedish neonatal staff and, for example, staff in the UK, and certainly the Swedish are more proactive if they are given case examples of situations so there seems to be a clear difference. I think that difference is driven by the experience you have. I mean, if you have done it in a certain way for the last 10 years, then that's the normal. So if you have been active for 10 years, that's normal. If you have been less active, that's normal. So I think it's just, I don't think it's any deeper explanation than that, really.
That's really insightful, and I think it goes to show that we've had a talk by a colleague from Japan, where again he's kind of expressed the view that because they've been proactive with resuscitation and the laws actually changed in Japan in 2004, so it's actually matter of fact to resuscitate babies pretty much in all the tertiary hospitals from 22 weeks onwards. And the experience there is obviously there's, I would say less of, I wouldn't call it resistance, but the culture more is being proactive at that particular stage. And I think the units in Japan have adapted to it, as the way he would describe the culture, to kind of say that it would take a lot for them to kind of then consider. One of the questions that I had, Magnus, in that context is, would parents...
Or maybe I could, look, just before you say that, I would just like to spin a little more or add a little more to my response, because I think there are still in some hospitals, in those hospitals that have recently changed after the new guidelines in Sweden from 2016, some hospitals, and among them Karolinska Hospital in Stockholm, they actually changed to being more active, and they now have a lot of discussion with their nurses and their staff and their doctors about, and they have some differences in opinion between the staff members on this. Well, should we really have been so active with this baby, and so on. So they do have these ongoing discussions. But for example, in my hospital, where we have a long-standing tradition of being more active, we didn't change really anything after the guidelines. So we don't have those discussions. So I think it totally depends on your experience.
My question, Magnus, in that context was, I mean, have you ever been in a situation where parents have wanted to stop neonatal intensive care and you've disagreed? And how do you address that in your culture or in Sweden?
Well, those cases are quite rare because I mentioned that parents in Sweden are very, very cautious in, or they don't really express any, or I think also that they trust the doctors and the healthcare staff to do the right job and to give them information that they need. So it's quite rare, but of course we have had some cases if the parents signal that they think that we should stop intensive care. Of course, usually that we would, I guess, I haven't been in a situation where that hasn't been a reasonable request. So in those cases, we would just get to the consensus that, yeah, we should stop the intensive care because it's futile. And I haven't been in a situation where the parents like to stop in a baby that we think has good chances of surviving. But the opposite, of course, can be the case that the staff we feel that also these cases are quite rare, that sometimes the staff and the doctors feel that this is futile, but the parents want to keep on going without, yeah, they just want to keep on. And then what we do is that we never go against the wishes of the parents. So what we do is that we have just repeated talks with them until we come to a consensus. You know, Sweden is the consensus. We have a consensus culture. People, yeah. The other countries, they have more. So in some countries, we like to compare ourselves with Finland, for example, where they have a more authoritative, that the boss says something and they do what the boss says. But in Sweden, everybody has to sit down and agree before we do anything.
That's really helpful. I've got another question from a colleague who works in one of our sister hospitals. So the way our network works, Magnus, is we have 3 tertiary centers, Oxford, Portsmouth, and Southampton, and we cater to about 14 sister hospitals, which are level 2s. Now, because we're currently developing our consensus guidance, we're obviously challenged by the fact that there are some babies who will deliver in our level 2 units because the mother is too far advanced in labor at 22 weeks. Now, I think obviously we discuss all those cases on a case-by-case basis and discuss transfer. In Sweden, do you have level 2 units? And if a baby was to deliver there, would you transport it to a tertiary center, and how would you approach that?
Yeah, that's a great question. And as you know, Sweden is very large and very scarcely populated. So our region, which is the northern part of region, more northern Sweden, we actually have 50%, half of Sweden's area, which is the same as the area of the whole UK. But there's only 1 million inhabitants, and we have smaller hospitals scattered in this area. So, and we are the only university hospital. So we have a transport service with a neonatologist and a neonatal nurse who are on call 24/7, and we have a transport service. Usually we will go by aeroplane, sometimes with helicopter for shorter distances, but usually it would be aeroplane or a special ambulance plane. So we would, in those cases, in some cases, if there's an imminent preterm birth, we could even get to the hospital before the baby is born. But in other cases, we would, of course, the local staff will do the initial resuscitation, and we would show up as soon as we can. So we would not have, in principle, any different handling. But of course, the competence of the staff will differ if they are born very rapidly in the local hospital.
Just another question from the audience at this particular point. In terms of neurodevelopmental follow-up for babies, say between 22 and 26 weeks, what kind of guidelines do you have over there? And what kind of questionnaires do you use? What standards do you practice in terms of how frequently you see them?
Yeah, we have the national guidelines says that there should be a standardized follow-up at 2.5 years and at 2.5 years corrected age and 5.5 years chronological age, and using standardized tests like the Bailey score for the 2.5-year-old and the now it's the WISC score for the 7 or 5.5-year-old. I think, and then there's also, of course, a motor development check by the physiotherapist, and there's an ophthalmological check, and there is a medical checkup, and so we have a long list like of standardized tests that are supposed to be done. I must say that this routine is working in some hospitals, but not in all hospitals, because some hospitals, they say that, oh, we don't have any funding for this follow-up, and they are not so extremely motivated. So I think this is an ongoing challenge and something that we're working up on to get these follow-ups to be done. Then on top of those national recommendations, we have local recommendations to follow at, for example, 2, 4, 9 months and so on, with like a standardized follow-up without this necessity of formal testing. Yeah, so that's about what it looks like.
There's one other question from the audience. So the initial cohort for 22 weeks had a high incidence of NEC, and we were just curious. We see a lot of spontaneous perforation in the early days, and do you separate spontaneous intestinal perforation from the cases of NEC when you're doing the analysis of morbidity from a GI perspective?
Yeah, this is an excellent question, and actually we are doing a project. We have published a paper on we went through all the cases of NEC in the Express study, and we tried to validate them using original files, and because we thought that the occurrence was quite low, and we thought, is this really correct? So we went through all the papers, all the files, and we found out that actually it was even lower, because there were some misclassifications, usually of the spontaneous perforation as NEC. So certainly, if you use this register data as we do now with the quality register, or if you do use diagnosis data, there is a tendency for doctors to put this NEC diagnosis even in some cases when there was really a spontaneous perforation of the gut. But we try to make this. We have actually tried to improve how this question is asked in the quality register, and we also do validations, and we go through this data. And as I said, we are actually working on this NEC data right now, and trying to see if, because it turned out that even though it was validated in one round, if you validate it even more properly, we will still find some cases of perforation in there. So I think it's a difficult, and I think there's some British data on which also supports this, that it's really NEC is a difficult diagnosis, and using, so really you have to use a very few limited number of persons who go through the actual clinical data to really know.
We have one more question from the audience with regards to the incidence of IVH and how you manage that in terms of kind of 22, 23 weeks. Do you feel it's a little bit more frequent amongst 22, 23 weekers in the early days? And say for babies who have bilateral grade 4s in particular, what's your approach to them?
So this is the incidence. As you see, this is grade 3 and 4, so it seems to be about 10 to 15% in the more recent cohort of 22 and 23 weekers. So it's not a very high incidence. It's maybe slightly higher than in the older weeks, but as you see, it's not really clear. It's not like, for example, our retinopathy of prematurity, where we can see a much clearer relation to gestational age. And of course, in those cases where we have a very severe grade 4 hemorrhage and a very, very sick baby on a ventilator, in those cases, many clinicians would have sit down and have a discussion with the parents and with that would be with the staff and everybody. Should we continue the intensive care or not? Yeah. So but I think also this practice in that part, in the resuscitation part, we have very nice national guidelines, but for this stopping intensive care part, we don't have any clear guidelines. And I think it's also difficult to write such guidelines, because then you enter some sort of legal territory, and it's very, very difficult to say something other than that the responsible clinician should take this decision in depending on the parents, the patient situation, and of course in discussion with the parents.
With regards to feeding them, how soon would you start feeds, say for babies at 22 weeks in your setup? And
we would start already as soon as possible within the first with small minimal enteral feedings. And then in Sweden, I think in the UK, you have a tradition of continuing minimal enteral feeds until the baby is stable. In Sweden, we have the tradition of actually increasing the feeds already from the start. However, in these very smallest babies in 22 weeks, if they are really sick and so on, it will be a very, very slow, if any, increase during the first days and then a gradual increase. And this speed of increasing feeds will also differ somewhat between hospitals, and this is always a source of this discussion. And there was this nice SIFT trial from the UK, which we look at, but in general, we would be most would be a little more cautious than those rates that were discovered there.
And your approach to management of ducks in the extreme preterm age group, we're a center in Southampton who are, I would say, fairly, I wouldn't say aggressive, but we're hot on medical management for, I would say, clinically and hemodynamically significant ducks in the, I'd say, first 10 days. But we're also a surgical center who ligates ducks, and we get a lot of ducks from around the country. We've clearly recognized that we are treating PDAs quite a lot. And I was just curious to get a little bit of a feel about your approach.
Yes, that's a great question. In Sweden, there was also a large variation between centers, and the surgical centers that had a high ligation frequency, and in those centers without surgery, there was much lower. And data from the original Express trial showed quite nicely, I think, that those that were operated had a surgical PDA, they had poorer outcome, and it was not related to the severity of the PDA. It was more related to those that were born in a hospital with more active surgery. So actually what has happened is that the active centers have become less active with surgery. With medical treatment, we would start not in the first days, but later on late in the first week and after, if there's a PDA with a hemodynamic importance, we would treat ibuprofen and sometimes paracetamol.
Very similar approach. That's fantastic. I'm just going to ask the audience, does anybody want to or have any other questions that they'd like to ask? That looks like
oh, hi, sorry, this is Jimmy. I don't know if you can hear me. Thank you for your time and the lovely talk. It's just a little bit of a personal question in terms of outcome for the 20-weekers. So as an intensivist, I don't know how much involvement you have with following up these kids. So my question is asking you what the best outcome has been for you, having managed a 22-week care. So perhaps maybe 2-3 years down the line, you look back and you think that was absolutely the right thing to have done. Do you get my question?
I didn't know. I didn't get the end of it.
So my
situation
question
was.
So my question is, in terms of follow-up, I don't know how much involvement you have with follow-up as intensivist, and what is your best outcome personally amongst the 22-week cohorts you've managed?
Oh, yes, we have, I would say, we have a few 22 weekers, especially those, I would say, in the range, the late 22 weekers that are completely normal on follow-up at school age. But clearly, as indicated by the results from Uppsala, as I showed, there is quite a high incidence of having some sort of either behavioral problems or cognitive problems. Usually, as you would see, as you know, with school. But we do see, as you also know, these babies usually can go to regular school, but it's quite common that they need some extra support in school. But certainly, I wouldn't. If you, well, I'm not personally. Some doctors in my unit do a lot of the follow-ups. I don't personally do so much. I do it sometimes, but not so much. So I'm maybe not the person to ask. I know the research results and the statistics from the quality register, but those we certainly see some babies that are, or some children that grow up to be seemingly perfectly normal. On the other hand, we also see some babies that have quite a lot of problems. So I mean, we have both of them, and especially in 22 weeks, we really see both of them. However, the really bad, like cerebral palsy, not able to go to normal school and so on, that's still pretty rare, even in the 22 weekers.
That's really helpful. Thank you so much, Magnus. I'd like to take this opportunity to give you a vote of thanks for giving us an absolutely excellent summary and talk on management. Obviously, we're starting our journey and we're behind, at the moment, but what we'd like to do is obviously assess and see how we move forwards. Interestingly, I think when we get our embrace data from next year, because the BAPM guidance was introduced, just actually formalized in 2020, it'll be very interesting to look at practice across the UK and see what and how many babies we're resuscitating at that particular gestation.
I'd like to show this slide at the end as an example of a healthy child. Yeah.
Thank you so much. I'm really grateful.
Okay, thank you very much. Bye-bye.
Thank you very much.
Thank you.
Thank you.